Hello and welcome to another emergency Q&A for families in intensive care and intensive care at home. Thank you so much for joining the live stream and also thank you for watching it on replay. Now, before I dive into today's questions, what makes me qualified to make a live stream or host a live stream for emergency questions and answers for families in intensive care and intensive care at home? So I'm a critical care nurse by background. I have worked in critical care for nearly 25 years in 3 different countries, where I worked as a nurse manager for over 5 years. And I've been consulting and advocating for families in intensive care here at intensivecarehotline.com since 2013. And we have saved many lives as part of our consulting and advocacy. I can say that without the slightest hint of exaggeration. I encourage you to check out intensivecarehotline.com, check out our testimonial section and see what our clients say, or go to our podcast at intensivecarehotline.com and check out what our clients say on the podcast. I'm also the founder and managing director of intensivecareathome.com. With Intensive Care at Home, we've been operating since 2012 all around Australia. We are sending critical care nurses into the home predominantly for long-term ventilated adults and children with tracheostomies as a genuine alternative to a long-term stay in intensive care. We are operating all around Australia. We are NDIS approved, TAC, WorkSafe in Victoria, iCare in New South Wales, and IISQ in Queensland, as well as DVA. We also have received funding through Departments of Health, public hospitals, and private health insurance. So go and check out intensivecareathome.com for more information. We're also providing level 2 and level 3 NDIS support coordination. Now, also, just let me know if you can't hear me. Just let me know in the chat pad if you can hear me. That would be helpful, but I trust that you can hear me. It seems fine on my end. Also, if you like my videos, subscribe to my YouTube channel, or subscribe to my YouTube channel, click the like button, click the notification bell, share these videos with your friends and families so we can help as many families in intensive care as possible. Now, if you have any questions, type them into the chat pad or join me live on the StreamYard link. If you don't have any questions, I will go to my numerous emails that are coming in during the week, and I will answer some of them. But you please feel welcome to type your questions into the chat pad or join me live on the StreamYard link by clicking on the StreamYard link that I posted in the chat pad here. Now, in the meantime, let's go to our first email from Heather. I'm just needing to scroll to it, where Heather says, apologies, I just need to get to that email. Yes, here it is. On March the 3rd at 1 a.m., Hi Patrick, this is from Heather. This is an email. Hi Patrick, on March the 3rd at 1 a.m., 911 was called and my father was taken by an ambulance from Kindred LTAC to the ER of a small older community hospital in Santa Ana in California. They sent nothing with him, and the ER nurse didn't even know he was diabetic when we arrived the next morning. The LTAC called us to inform us at 7 a.m. They had diagnosed him with sepsis due to infection caused by recent G-tube insertion into the stomach. There were also some chest x-rays showing free air where it shouldn't be. They hydrated him, contacted his ID doctor, and continued antibiotics. I asked for a transfer to a higher level of care, University Research Hospital, but was refused a transfer because he had been transported to this place. His vitals were good, his white cell count was good, and his lungs looked good, except for the bacterial pneumonia he was already being treated for. It was a Pseudomonas bacteria. The next day, while being repositioned, his tracheostomy became dislodged and he was unable to be put all the way back in. His oxygenation was still measuring between 99 and 100%, and he was talking. The surgeon who has done the trach was called, but he was in heart surgery all day. Eventually, they called a pulmonologist and said he would perform a bronchoscopy and re-intubate through the mouth, but he was able to reposition the tracheostomy correctly. The free air was gone, so it was decided that he could start back on liquid diet slowly. Because he was already in this hospital, the foot surgery was scheduled. The MRI of his heel showed 3/4 of the heel bone were infected. He was cleared for surgery and had an angiogram and angioplasty for legs to make sure that his circulation was good. Then he started vomiting. They said it was nerves and the feeling of the tracheostomy being uncomfortable, discontinued feeding, and he was still vomiting. We pushed back that this was not his baseline, even with a tracheostomy. We finally got another chest CT and GI, and we thought it looked like the G-tube had gone through the bowels. They did a colonoscopy to confirm, and he also had the foot surgery. It turns out the G-tube went into the colon and out of the colon, ending in the stomach. He had abdominal surgery for colon bisection and colostomy the next day, Thursday. On the 14th of March 24, the surgeon reported that they found no leakage from the colon. One of the other doctors that came in mentioned a pus-filled sac that the GI surgeon was able to remove intact and that they would culture it. On Saturday, we found out that it was Pseudomonas. They changed the antibiotics to levofloxacin, so I'm assuming the others are not, and moreover didn't work to control the infection in the past in spite of my father's great white cell counts. Pseudomonas was in the original infection ulcer in my father's left foot that was operated on in July 2023. We tried in the past to get the phage therapy and IV vitamins as well as probiotics, but were constantly shut down. This place also has a policy of not giving any records, online charts, etc. until 10 to 15 days after discharge. We have been staying for all of visiting hours trying to gather information. After the ER, my dad was moved to a telemetry floor. After the first night, one of us was allowed to stay over and sleep on a cot in his room. That was good for suctioning vomit immediately and trying to prevent vomiting. After abdominal surgery, he's in the ICU. They refuse to give my father family representatives info about procedures, results, etc. and say, just ask the nurse. So, where are we now? Number one, in ICU would be an appropriate placement. Number two, IV levofloxacin, TPN, glucose or dextrose is needed to treat low blood glucose, check every 6 hours. Trickle feed trials through the PEG tube. Inhaled bronchodilator and tobramycin. Number five, subcutaneous insulin is needed to control high blood glucose, check every 6 hours. Number six, allow dose of blood thinners to start treatment for thrombosis or for thrombus found in his right brachial vein in the right arm. Number seven, ventilator off during the day and on the TPs or trach mask with 28% oxygen during the day, on the ventilator at night. What questions should I be asking from Heather? Wow, that is full on, Heather, and thank you so much for sharing that. That is a full-on situation. Let's break this down for everyone. It has so many ingredients in there that I've been warning against for many years here on my YouTube videos, on the blog at intensivecarehotline.com. You know, so many takeaways in there that I've been warning against for many years. Let's start. He was at Kindred LTAC and then he ended up in ER. Now, what have I been saying for many years? That patients in LTAC cannot be looked after there if they're ventilated with a tracheostomy. I've been saying that for many years. I've been seeing it almost weekly where we get contacted by families that their loved one went from LTAC back to ICU. It is almost unbelievable in terms of how many times this is happening, right? So what can you do against it? Never ever give consent to going from ICU to LTAC. That's number one. You need to ask right from the start, what is ICU doing to prevent the tracheostomy? What is ICU doing to get your critically ill loved one off the ventilator and the breathing tube? That is the first question that you need to ask, assuming your loved one is ventilated in ICU. Again, LTACs, sorry, I forgot to mention that. LTACs are specific to the United States. There are no LTACs in other countries, such as in Australia or in the UK. They simply don't exist. In the US, many patients in ICU get moved towards a tracheostomy and a PEG tube as quickly as possible, and then they get shipped out to LTAC. And LTACs are a dangerous place. They're not equipped to basically look after critical care patients. And that's when patients bounce back into ICU, which is exactly what the email from Heather here describes so vividly, right? So he ended up with the sepsis. They had diagnosed the sepsis due to infection caused by the recent PEG tube insertion into the stomach. Now, what have I been saying once again for many years on my podcast here? Do not give consent to a PEG tube. Never, ever. A, there's no need for a PEG tube. Research has shown that patients are perfectly fine with a nasogastric tube, right? That's number one, and there's research out there. It's not only my professional opinion. There is research out there. That's number one. Number two, if you don't give consent to a PEG tube, if you are in the US, chances are very high your loved one can't go to an LTAC because LTACs can't look after a nasogastric tube. And that should tell you everything you need to know about LTACs and about their skill level, right? Their skill level is so poor that they can't even look after a nasogastric tube, right? Now, and here is another word of warning. I've been saying for the longest that by giving consent to a PEG tube, it requires surgery. Why would you send your loved one through another bout of surgery? Why? That is madness as far as I'm concerned, especially if there's an alternative that just works as well. Just works as well. You need to keep a close eye on nasogastric tubes, don't get me wrong. But, you can do that by having appropriately skilled nurses there, right? So next, because Heather and her family have given consent to a PEG tube, that's why her father ended up with a, what does it say again? Diagnosed sepsis, right? Yeah, the PEG tube went into the bowels, causing septicemia, right? So again, this comes out of a procedure that should have never been given consent to in the first place. Never, ever. Now, to illustrate that once again, because I mentioned that in other countries, such as in Australia or in the UK, LTACs don't exist. That's why long-term ICU patients in those countries don't need a PEG tube. They're perfectly fine with a nasogastric tube unless they go home and are still ventilated with a tracheostomy. That's when a PEG tube comes in, right? A PEG tube has their time and their place, but not after a couple of weeks in ICU to send patients to LTAC. Most of our clients with intensive care at home, if they're ventilated, have a tracheostomy, have a PEG tube. But that's a completely different scenario because those patients have shown the inability to wean off the ventilator and the trach beyond the shadow of a doubt. So there is a big, big difference there. Huge difference. So PEG tube surgery, or any surgery for that matter, comes with undesired side effects, right? So once again, why would you give consent to surgery in the first place? Right. So then he had aspiration pneumonia, right? Oh, no, not aspiration pneumonia, bacterial pneumonia. He was already treated for that. The next day, well, his trach became dislodged. Yes, his trach became dislodged. And they had to put it all the way back in, which would be extremely uncomfortable, right? And again, the risk for something to go wrong here, and the risk for someone to die is very, very high, right? So then his foot surgery was scheduled, and the heel showed 3/4 of the heel bone were infected. I argue that is also a result from substandard care in LTAC. That is substandard care in LTAC, I argue, right? Because again, we've seen it. I would have made other videos here and questions that I've answered where, you know, patients in LTAC get pressure sores because they're not getting mobilized, they're not getting the right level of care. They often work with, excuse me, with LNPs, not with ICU nurses. It is just inappropriate care standards. So then the email carries on. He was cleared for surgery, had an angiogram and angioplasty for legs to make sure his circulation was good. Yep, then that's good. He started vomiting. They said it was his nerves and the feeding of the trach, the feeling of the trach being uncomfortable. Discontinued feeding, and he was still vomiting. We pushed back that this was not his baseline, even with the tracheostomy. We finally got another chest CT, and GI thought it looked like G-tube had gone through the bowels. They did a colonoscopy to confirm, and he also had the foot surgery. It turns out, and it was confirmed, that the PEG tube went into the colon and out of the colon, ending in the stomach. He had abdominal surgery for colon bisection and colostomy the next day. You know, you can see why I am so anti-PEG early on, right? Because of the complications. The nasogastric tube doesn't have the same complications. Again, I do highlight the difference for home care. If someone has shown the inability to wean off the ventilator and the tracheostomy, for someone with a spinal injury, you know, for someone with neurological conditions, MND, and so forth, that is when a PEG is absolutely appropriate, but that's the exception, not the rule. The overwhelming majority of patients in ICU do not need a PEG tube. Simple as that. Now, it's got Pseudomonas. They changed, you know, it's got the high white cell count. What else was there? Oh, yes. Then Heather says this hospital also has a policy of not giving any medical records, online charts, etc., until 10 to 15 days after discharge. Well, what do I say about that? Well, I know you're in California. I can see that from your email. Well, in California, I can assure you that you have the right to access medical records. So they're lying into your face, right? You have the right to access medical records. It's not a privilege. Most hospitals now, in the US in particular, you download the MyChart app and you can access medical records through the app, and you can see in real time what's happening. And that's how it should be. Healthcare needs to be transparent. What is it that they have to hide if they're not showing you the medical records? And I can assure you that all of our clients that we work with over the years, they all have been able to get access to the medical records. We can help you by talking to the hospital directly, reminding the hospitals of their obligations to you and your family. So I hope that this is giving you a really good idea of what can go wrong with the PEG tube, what can go wrong if your loved one goes into LTAC in the US, right? It's never, very rarely has there been a good outcome. Very, very rarely, unfortunately, right? So then, because this subscriber sent a few emails, let's just move on to her next email. And before I move on to the next email, type your questions into the chat pad or join me live here on the StreamYard link, and you can talk to me directly. And I'll read out the next question in the meantime while there are no other questions. So this is the follow-on question from Heather, who says, "Hi, Patrick. My dad is stable for the moment in ICU again. 2 days ago, we got a call in the middle of the night that he needed emergency surgery. It seems they had attached the wrong end of the colon to the colostomy. They said this was due to my father's sigmoid colon being enlarged and in the place where the transverse colon usually is. It turns out that it was actually the sigmoid colon that was originally punctured by the original PEG tube. He was taken off the high dosage of blood thinners, Levodox, that he was on, infused with fresh frozen platelets, and operated on about 8 hours later on March the 22nd. Less than 22 hours later, the internist put in an order that my father should return to the LTAC. However, the current hospital notified us of this, and we and the RN notified the GI surgeon. The GI surgeon says, no, my father is not ready to leave the hospital yet. So, next, here is the doctor's plan. He's not well enough for subacute care or LTAC. There are too many issues. When he's discharged, it will be to the LTAC. Diagnosis: sepsis, infections. His white cell count is normal. He's got a Pseudomonas infection, MRSA infection, and a VRE infection. He's got the Achromobacter zilosodans. He's on metronidazole 500 milligrams, daptomycin powder, levofloxacin. Since no new infection found during the last surgery, antibiotics will end when previously scheduled to in about 6 days. He's got the bone infection on his right heel, partial amputation performed. Listen to this, a partial amputation performed due to nursing or medical negligence in the LTAC because they could not keep this man free of pressure sores. That is nursing 101, to keep patients free of pressure sores. So it's just such a bad situation all the way around. Now, antibiotic beds injected, wound vac. Now he's got a wound vac. So this patient goes from ICU to LTAC. He ends up with a bowel perforation because of the PEG tube. He ends up with a foot amputation because of going to LTAC and the inability of the LTAC to provide proper pressure area care. Unfortunately, this is not unheard of, but unfortunately, this is what happens when families don't pay enough attention to doing enough research, doing your own research, doing your advocacy, making sure you know what to look for, what questions to ask, what are your rights from day one, so that your loved one doesn't get into a situation like that. Next, Heather continues there. Colon anatomy abnormalities due to constipation, lack of motility, possibly related to being long-term type 1 diabetic, surgery, bowel bisection, insertion of a new PEG tube into the stomach, only colostomy corrected, colostomy gas but no bowel motion yet, medications, Reglan given every 8 hours, Pepsid every 8 hours, Zofran as needed. Now, with Reglan, the other email that I read out before, Heather's father was vomiting. That is probably why Reglan needs to be given, because Reglan helps with digestion and food absorption. Nutrition, Heather continues, nutrition. TPN with the new G-tube had tolerated tube feeding. It was stopped because of wrong end of colon brought up to colostomy. But TPN has insulin added to it that seemed to cause his low blood sugars. Yesterday afternoon and at night, the nurse had asked them to adjust the TPN. They said they were giving the colon a rest. I will ask when they will start trialing tube feeds again. The wound vac for incision in his wound, bed sores on his bottom, wound care specialty mattress, turn every 2 hours. So now he ended up on TPN. I mean, you know that I'm an advocate for TPN for the right patient. However, and TPN is necessary, but TPN should have never been used in the first place by avoiding a PEG tube and by just using a nasogastric tube. Then right arm in proximal right, brachial vein. He's got a thrombus there. Today they restarted the Levodox at low dose. The plan is to keep increasing. Then fluid retention medications, is on Lasix and he has a Foley catheter. Then Heather continues, in the United States, it is only one private for-profit company that does LTAC, although there are different locations. At the previous LTAC, they let his foot wound become infected. They let him aspirate and get a pneumonia, needed to go on a ventilator, and perforated his colon and let him get septic before calling 911 and dumping him at the emergency department. Oh, this is heavy stuff, folks. This is heavy stuff. Now, it is not it is not true that in the US there's only one private profit company. There's definitely Kindred is a huge LTAC provider in the US, but there are other providers for LTAC as well, such as Select Specialty, and there are other smaller providers, right? So that is not accurate that Kindred is the only private LTAC provider in the US. So then Heather continues on. We want to take my dad home, but the doctor says training to help with the trach and ventilator will take a long time. We're trying to find options for skilled nursing care at home. It seems like this is a common practice for children who have a tracheostomy and a ventilator, but not for adults in Southern California in the US. Yeah, look, I know there's help for ventilated kids out there in the US, all around the US, and probably in Southern California as well. If you want to take your dad home in a situation like that, I would strongly encourage you to contact us here at Intensive Care at Home, because that is what we do with Intensive Care at Home, and your dad is so much better, will be so much better off at home. It's a win-win situation. Now, and we're looking after many similar clients at home in Australia compared to what situation your dad is in, So let's move on. It's a long email. Heather continues. Previous to the latest operation, he was back on the TPs during the day and they were going to order a speaking valve. The LTAC didn't send with him or give to us when we tried to get his things. They have done a blood gas daily and have said it is, and she puts in quotes, very good. Today, he was on CPAP, then the TPs, which is similar to the trach mask or trach collar, and he was tolerating both well. The blood gas was done, results were good, also monitor showing between 97 to 100% of oxygen with 28% oxygen. Their plan is to get him back to the TPs all day and the ventilator at night, because that is how he was when he entered this hospital. Now, before I carry on with Heather's email, just, what does an arterial blood gas looks good? What does that mean? So I would hope that they've done the arterial blood gas while he was on the TPs and not on the ventilator, because you want to do the tracheostomy, you want to do the blood gas on the lowest settings, right? Because if the blood gas is good on the lowest settings, you can then, potentially even reduce the support, right? Don't do the blood gas on the highest settings, because the results might be masked. Okay, so then Heather continues. Their plan is to get him back to the TPs all day, ventilator at night, because that is how he was when he entered this hospital. However, before the latest operation, he seemed like he would be able to go longer because his heart rate was staying stable and oxygenation was at 100% and he wasn't fatigued. As he heals, my plan is to ask for more time off if he tolerates. Sedation. He's not sedated as such, and he shouldn't be when he's having a tracheostomy. He absolutely shouldn't be sedated with a tracheostomy. That is one of the main purposes of a tracheostomy, stop sedation, because a tracheostomy is so much easier to be tolerated compared to a breathing tube. So sedation is not sedated as such, but the two things that he has available for pain as needed are IV Tylenol and morphine. It was deloaded, but he does not do well on that. Hallucinations, stress, paranoia, doesn't recognize family, which leads to sweating, increased heart rate. So, next, mentally, my father is alert and responsive and able to follow directions and signals to get needs met. He's using today, he can move his upper extremities and is working on uncurling his fingers. Last week, he was weak, but able to swing his legs and sit at the edge of the bed for a while with OT. Today, he was worried because he can't move his legs. It has to do with the device on his lower legs to help with circulation, the nurse thinks. Regarding breathing and coughing, exercises, where do you suggest? Do I look information about that? We have been asking for months about passive range of motion exercises for his legs. We were told he had to be cleared for that, and after he was, they only came once. Can you suggest a source for me to look at? Yes, I can suggest a source. We are the source here at intensivecarehotline.com because we've been covering this for many years. Your dad needs to get physical therapy, right? You can, and that includes breathing and coughing exercises. Both needs to happen. When he's off the ventilator with the tray collar, the physical therapist or the respiratory therapist should be doing breathing exercises with him. Breathe in, breathe out, sit him on the edge of the bed, get him in a chair, maybe do some marching on the spot, right? Coughing exercises, yes, very important that your dad can clear his airway. So sit him up, do some coughing exercises, very, very important, right? So we have been asking for months about passive range of motion exercises for his legs. We were told he had to be cleared for that, and after he was, they only came once. Again, put the pressure on, ask them for what you want. Really, really important that you ask them for what you want. The squeaky wheel gets oiled, and if you want us to help you with a formal complaint, we can help you with that. We have made many formal, successful complaints. It comes down to writing to hospital executive or writing to doctors and nurses in the ICU. Can all be done. Because if you're not doing it, that's when your loved one doesn't get best care and treatment. Next. Mentally, my father is alert and responsive. He's using some printed core boards to communicate along with gestures and spelling things out on one with alphabet and numbers. Right. Okay. Well, Heather, thank you so much for sharing all of that with us. And, just by going through this, it's another devastating example why patients in the US should not go from ICU to LTAC. Simple as that. As simple as that. Now, if you have questions that you want to have answered, type them into the chat pad or join me live on the StreamYard link here. If not, I will continue with reading out emails. Let's see whether Heather, there was another email. If not, I will get to other emails. There's no shortage of emails. I just need a second to get to the right one. Okay, so okay, now there's no other emails from Heather. Let's move on to the next email then. And like I said, if you have any questions, type them into the chat pad or join me live on the StreamYard link here. The link is in the chat pad here. Okay, so let me scroll to my email. Sorry guys, I just need a second to make order here, but go back to what I've talked about. If you're watching this on replay, you might want to watch that section again with this devastating situation for Heather, right? And for example, on Friday, I was actually on a call with a client, with a case manager in the US, talking about the same things. The case manager said, well, what we do here is we send patients to LTAC. And I encouraged the family to say, well, that's what you might do here, but that you're not going to do that with my family member. And I think for now we succeeded, right? Because we gave them all the reasons why their family member should not go to LTAC. Never, ever, right? So, I'm in constant conversation with those families, right? Because that's just the reality. Do not go to LTAC. Okay, let's move on to the next email from Donna. Donna says, hi, Patrick. My brother has been in an induced coma for over 2 weeks now, and when the doctors reduce the sedation, he is not waking up. We are very concerned. Is there any hope left that he will recover? Now, Donna, why would he not wake up when they reduce sedation? If he's not waking up when they stop sedation, that would be of concern. But if he's not waking up when they reduce sedation, does that mean they increase it again? Right? Is there any hope left that he will recover? I don't know. you need to tell me more. Have they done a CT scan of the brain, MRI scan of the brain? Is his liver working? Is eyes, kidneys working, right? Okay, so then let's move on to Nada's question here. Hi, Nada, thank you for asking. You're saying, hi, Patrick, my aunt is on mechanical ventilation since the 9th of July. She has not moved to ICU and is in a palliative care hospital. She's still with a tube in the mouth. Is it better to do a tracheostomy? Nada, that sounds very strange to me. And I'll tell you why it sounds strange to me. So July the 9th, that means we're coming close to a month, right? So if your aunt cannot come off the ventilator, right, she should have a tracheostomy. That's number one. If your aunt wants palliative care, right, there's no point in keeping the breathing tube, right? Palliative care most of the time is end of life care. So what's the point in keeping a breathing tube in if your aunt or your family wants palliative care for her? So the question here is, what does she want, right? If you want her to live and she can't come off the ventilator and the breathing tube, absolutely need to do a tracheostomy. Absolutely. If you want her to be in palliative care and you want her to pass away, and your aunt and your family is in agreement that needs to happen, then take out the breathing tube and let her pass away. She's also on propofol, fentanyl, and midazolam. That is heavy stuff. Why is your aunt on a ventilator? Why? Please share with me why your aunt is on the ventilator. But if she's on propofol, fentanyl, and midazolam, of course she can't be weaned off the ventilator. Of course she can't, because she needs to be awake, right? So why is it that she's on propofol, fentanyl, and midazolam? Now, if you want palliative care for your aunt, you take off propofol, fentanyl, and midazolam, she will probably pass away when you take out the breathing tube, right? Again, this is a question here where it becomes abundantly clear that the biggest challenge for families in intensive care is that they don't know what they don't know. They don't know what to look for. They don't know what questions to ask. They don't know their rights, and they don't know how to manage doctors and nurses in intensive care. So now you're saying, Nada, I believe the family that agreed to the ventilator was saying it would help her pass more peacefully. Not really. Not really. Imagine passing away with a tube in your throat or passing away without a tube in your throat. So that argument doesn't count as far as I'm concerned. A tube in your throat does not help you to pass more peacefully. If anything, it's the opposite. Right? Now, what else is there? What else is there to this situation? Because it sounds to me like there's either some confusion or there's things you don't know. Now, why is your aunt in ICU in the first place? Why? And you're welcome to join me live on the show here, and talk to me directly. That might help you quicker. I'll just post the StreamYard link again. While I'm waiting for your explanations, I'll just go back to the email from Donna, where she says, my brother has been in an induced coma for over 2 weeks, and when the doctors reduced the sedation, he's not waking up. We are very concerned. Is there any hope left that he will recover? Donna, he should be off sedation completely, right? And then you can make an assessment whether he's waking up or not. If he's on and off sedation, well, you can't really make an assessment whether he'll wake up or not, right? And really what they need to do is they need to do an MRI scan, CT scan of the brain, assuming sedation and opiates are off completely, right? Next, Nada, you're saying it was sepsis. She also has other comorbidities, mainly cancer. Sure, I understand that, Nada, but that doesn't, it should not change and that won't change what I talked about before, that either they're doing a tracheostomy or they take out the breathing tube and move her towards palliative care. Leaving a breathing tube in whilst being on morphine, midazolam, and propofol and not doing a tracheostomy doesn't make any sense while simultaneously talking about palliative care. Doesn't make sense. It does not make sense. Right? So I have no idea what they're trying to achieve here. I really don't know what they're trying to achieve. You know, what does your aunt want? What do you think she wants? You know, that's really what it comes down to. But if they keep her sedated for longer, she's already deconditioned, right? She would already be deconditioned. And the longer you keep her sedated, the longer the more deconditioned she will be. You're saying, thank you for the explanation. The doctors here are not explaining much, if at all. Yeah, sure. That may be the case, that they're not explaining much, but it also comes down to you asking the right questions. So now you have a better idea what the right questions are that you need to ask, right? Now you have a better idea of that. Okay. I would also, if I was you, sorry, I've been chatting away whilst I had my microphone on mute. I do apologize. Sorry. Nada, I said you need to get access to the medical records as quickly as possible, right? Which is what you need to do in a situation like that. So then you're also saying, so if they choose to keep her alive and have hope, doing a tracheostomy and removing sedation would be the next step. Absolutely, 100%. You're right on the money there. Yeah, sorry, my apologies. I was on mute. My apologies. So yes, get access to the medical records. But if they choose to keep her alive and have hope, doing a tracheostomy and removing sedation would be the next step. 100%. 100%. There is so much research out there, Nada, where a tracheostomy should be done after about, 10 to 14 days of mechanical ventilation. Right? There's so much research out there. Right? So I really don't understand why they are talking about palliative care and keep her ventilated. It doesn't make sense. It does not make sense at all. So I hope that's giving you some ideas what needs to happen next here. Okay. I'm also curious to hear which country you are in, Nada. I'm not sure whether you're happy to share which country you're in, because this is a very unusual approach as far as I'm concerned. Sometimes it might depend on the health system of the country. Okay, so next question is from James, who says, my mom is in ICU and I get very vague answers of why she's stuck on the ventilator and seemingly can't be weaned. That's an interesting comment there from James. Look, if your family member can't be weaned off the ventilator, you should absolutely be asking why. And you should be asking for a weaning plan, right? And you should be asking for access to the medical records, right? And you should be, finding out what are arterial blood gases like, chest x-rays. Other things you should be looking for is she getting mobilized, right? Is she still on sedation? Those are all very important aspects when someone supposedly can't be weaned off the ventilator. Okay, I hope that answers your question there, James. Let's move on to the next question. Or Nada, if you wanted to continue the conversation here, please keep doing that. Sorry, while I'm looking. Nada says, yes, thank you so much. This helps me understand and to be able to explain to my family. We are in Kuwait, so maybe there are some difference in palliative care due to religion. There could be. There could be. There may be a difference in Kuwait being a Muslim country. Yep, that might be the case. However, we have been consulting families in the Middle East too. And as far as I can see, the difference in the Middle East, as far as I have seen, is really that, if anything, ICUs do not talk about end of life as fast as in other countries. They don't seem to be as pushy. There seems to be more emphasis on rights for patients and families and what they want. And that might also go hand in hand with religion. So then you're saying, Nada, the doctor that told them to put her on ventilator explained that she needs it because she's suffering, struggling to breathe. Yeah, that makes sense. However, here's the thing. So the doctor told them to put her on the ventilator, explained that she needs it because she's suffering, struggling to breathe. Okay, so I just need to go back to you said she went in with sepsis. She also has other comorbidities, mainly cancer. Okay. So if she went in with sepsis and she couldn't breathe, right, and she couldn't breathe to the point where it was compatible with life, yes, she had to be put on the ventilator, for sure. But then that would have bought her time initially, okay, but then the next question would have been, what are we doing from there? Are we going to keep her ventilated? If we are going to keep her ventilated, how quickly can we wean her off the ventilator? By putting her on morphine, midazolam, and propofol, you can't wean her off the ventilator. It's just not happening, right? So you're taking those first steps by putting someone on a ventilator, you're buying them time, you're stabilizing them, and if you can't wean them off the ventilator by reducing sedation, then if you want to continue treatment, then a tracheostomy is the next step, right? If you don't want to do a tracheostomy, then you can start the conversations around palliative care. That's assuming someone has a terminal illness and is not getting better. But then in your aunt's situation, from what you've shared with me, they should have taken away the breathing tube and should have discontinued propofol, morphine, and midazolam and given her smaller doses of that to help her with end-of-life care. But again, this could also be perceived as euthanasia if you give morphine, propofol, and midazolam, because it makes people stop breathing and it hastens death, right? But she might have just passed away by taking the ventilator away, depending on how unwell she is. So this is a tricky situation, Nada, but hopefully I was able to shed some light on what you might want to do next here. And you can also, because you can also reach out at intensivecarehotline.com. Maybe we can, maybe we can hook up for a proper consultation, and maybe you can get access to the medical records. We can do a proper consult. And then we can go from there. Again, just reach out through intensivecarehotline.com. Okay. And if the ventilator is removed, how can they make it a peaceful death? Yeah, continue with strong sedation, absolutely. So here is what happens. Palliative care situations in ICU for someone on a ventilator with a breathing tube. You can take out the breathing tube and you can leave sedation running, and therefore a patient will stop breathing very, very quickly. Now, if that is within your belief and cultural norms, I argue when you take out a breathing tube and you don't use sedation, right, you give a patient a fighting chance if they can breathe. If you take out the breathing tube and you start morphine, midazolam, propofol, it will inevitably make a patient stop breathing. And one could argue, could that be perceived as euthanasia? Because those medications, when someone is off the ventilator, may hasten death. They may hasten death, right? It would be peaceful, though. It would be peaceful. You know, patients might struggle to breathe without sedation, right? Without opiates, they might struggle, right? One could argue, but that's also a chance for them to live. So then you're saying, yes, thank you. I was thinking about a consult, but it's been very difficult to get information. If I can get the records, I will. By the way, she's not in ICU. She's in a pain clinic for cancer patients. Okay. It's interesting that you say that again, and that might be the difference compared to Kuwait and, you know, countries like US, Canada, Australia, UK. However, I argue, even though she might be in a cancer pain clinic, if she's on a ventilator, she will still need ICU nurses, ICU doctors. ICU nurses would be looking after her 24 hours a day. There's no question about that. ICU doctors would need to oversee her care at the very least, right? But there might be differences. But I still argue this must be a setup like in ICU, right? So I'm glad, Nada, I was able to help you and explain this to you, that, you know, there are many nuances to this, many nuances. It's not a one size fits all, you know. And also what you haven't mentioned here is, what does your aunt want? Surely you and your family would be making decisions that are aligned with what your aunt wants. You know, has she mentioned anything that if she ever is in a situation like that, what does she want? And with the cancer, is she in a lot of pain? If she is in a lot of pain, you know, maybe the focus needs to be on pain therapy. But one thing I can tell you, having the breathing tube in the throat is very uncomfortable. Very uncomfortable. You know, so there may be pain from the cancer, and then there's the discomfort or pain from the breathing tube. Okay, we have time for another question. I will wrap this up at the hour mark. We have time for one more question or another if you had any other questions. So I have an email here from Francis who says, "Hi Patrick, my loved one had a cardiac arrest which was caused by a lumbar puncture procedure. How much to investigate and what questions to ask?" Ooh, that's very sad to hear that cardiac arrest was caused by during a lumbar puncture procedure. Now, I have seen lumbar punctures in ICU. Most of them go uneventful. There is a risk that during a lumbar puncture you can cause a spinal injury that could cause, you know, a spinal injury, including quadriplegia, paraplegia, depending on the level of the lumbar puncture and the level of the injury. I would imagine that one of the next steps is to do a CT scan or an MRI scan of the back, right? And also potentially do an angiogram or do a heart ultrasound and so forth. You know, that's what I would be looking for. But I would also be asking for, is there any permanent damage from the lumbar puncture, i.e. spinal injury? Okay, so then coming back to you, Nada, you're saying that is a problem. No one is sure because she has never particularly discussed ventilation. But we know she has several times asked for euthanasia due to pain. Right, I see. Okay. Even though she's religious and it is against her religion. Yeah, I can see that. Yes, it is hard. It is very hard making those decisions. You know, there's no question about it. In some countries, there are now initiatives about voluntary assisted dying, where people can opt for voluntary euthanasia, right? I'm not a big friend of it because of the slippery slope. I believe, you know, this will get us to, but it is an option in some countries, and there is definitely a case for, what some people might refer to for a dignified death, in a situation like that. Yeah, it's very difficult. Nada, there's no question about that. This is a very, very difficult situation. And you need to think your options through. But it also sounds to me like no one has given you enough options, Okay, so if there are no other questions, I'm going to wrap this up in a minute. If you have a family member in intensive care, go to intensivecarehotline.com, call us on one of the numbers on the top of our website, or send us an email to support@intensivecarehotline.com. We have a membership for families of critically ill patients, and you can become a member if you go to intensivecarehotline.com, if you click on the membership link, or if you go to intensivecaresupport.org directly. And you can become a member there. I also do one-on-one consulting and advocacy over the phone, Skype, Zoom, WhatsApp. I talk to doctors and nurses directly, and making sure you make informed decisions, have peace of mind, control, power, and influence, so that you can influence decision making fast, making sure your loved one gets best care and treatment. Now, Nada, just quickly coming back to your questions, I have been wondering if they can wake her up to ask her before she was put on heavy sedation. She was communicating with the board, but never said anything about euthanasia. Yeah, I think that's a very good idea to wake her up and communicate with her. I think that is a very good idea. Right? I think euthanasia is definitely happening when doctors and nurses use sedatives and opiates without patient consent. If a patient wants to die, I wouldn't label it as euthanasia. I would label it as voluntary euthanasia or voluntary assisted dying, right? There's a difference there. It might be possible, but it might not be in your country. I really don't know. Okay, now with intensive care at home, go to intensivecareathome.com. If you need critical care nurses in the home, we're operating all around Australia, in all major capital cities and in all regional and rural areas. We are an NDIS approved service provider, DVA, TAC in Victoria, WorkSafe in Victoria, iCare in New South Wales, NIISQ in Queensland. We are providing level 2 and level 3 NDIS support coordination as well. And we're also currently hiring critical care nurses in Melbourne, Brisbane, Sydney, Albury, Wodonga, Bendigo, Warragul, in country Victoria as well. Now, if you like my videos, subscribe to my YouTube channel here for regular updates for families in intensive care. Click the like button, click the notification bell, comment below what you want to see next, what other questions and insights you have. Share this video with your friends and families. I do a weekly YouTube live, usually on a Sunday, 10:30 a.m. Sydney, Melbourne time, which is 8:30 p.m. currently US, on a Saturday night, Eastern time, which is 5:30 p.m. Pacific time right now during the summer period in the US. Those times will change when the US will go into when daylight saving finishes, but that's a while away. And thanks again for coming onto the show. Thanks for watching. Thanks for your support. I'll talk to you on another live stream or during the week with my quick tips. Take care for now. All the best.